So I think we're working. I'm not sure if anybody is on it. Um, just need to see and make sure that we're all working. If you give me 1 second. Right, so it is working. It took me a little bit just to get going. So I can now see in the chat stream. So if you see that, I can see hi. If anybody else is here, if you maybe just say hello in the chat stream, then we know what's going on. That's great. I'm Mark Frame. I'm one of the orthopaedic consultants and surgeons at Southampton General Hospital. I do adult knee, soft tissue knee and trauma. I also do pediatric soft tissue knee. And this will all make perfect sense when we start going through what we're going to cover tonight, which is the British sort of Children's Orthopaedic Society have done an update on the important aspects of managing a service that that can treat children appropriately with the right skill set. So again, let's see if I can make all of this work. So we'll go to the first slide. So the aim of this guidance really was to produce something for everybody. That's those referring, those rehabbing children, those seeing patients beforehand, whether they're physios, whether they're orthopedic surgeons, on how to produce a safe and effective and reproducible service for children's knee problems. Interestingly, it's one of those things that's quite a specialised service. So pediatric orthopedics in general has always been quite varied. So there's an expectation of being able to cover a lot of different specialties in that. In bigger hospitals and in general, specialisation is really kind of taking hold, and everybody to be very skilled and to be able to carry out those surgical procedures and manage those patients really focus down their interests. And that's no different with pediatrics. But they are still spread slightly more thin with their skills than the adult surgeons. So this paper and guidance, in the process of making it, they did a lot of surveys with orthopedic surgeons around the country and actually compared that with information that they'd gained from all over the world. So 25% of pediatric orthopedic surgeons treat ACL injuries, where 85% of adult surgeons will treat ACL injuries in children. And that's been very typically the model in a lot of places, where those surgeons that are doing soft tissue knee reconstruction regularly and arthroscopic surgery tend to be called in to do the ACL reconstruction in children. And it's important how that mix and merging of those two specialties and disciplines go together in being able to provide that properly, because children aren't just small adults. So 85% of adults and ped surgeons only do 10 or fewer children's ACLs a year. So that doesn't seem that many, and it's not. Interestingly, there's a getting it right first time, which is something the British Orthopaedic Society are pushing quite hard. And for joints, for instance, for doing joint arthroplasty, if you're doing 10 or less, then they probably think you shouldn't be doing it. So that puts it into context. If the majority of people that are doing soft tissue reconstruction are doing 10 or less children a year, that's not particularly great. So it's really, really important that it's a multidisciplinary setup. So why is this a problem? It's not some little niche anymore. It's not one of these things that there's a few children a year and actually we don't really need to bother about guidance and how we work this through, because we'll just muddle through with the few that we have. It's one of these things that's rising quite significantly. And the reason that it's rising is that there are more children participating in sport at a much higher level. Interestingly, there's a much higher female participation in contact sports. Increasing BMI, we all know, we all see it around about us, but that translates into bigger injuries in children, or a mismatch in children that are participating in contact sports, where you've got a 13-year-old who can be 70, 80 kilograms versus a 10-year-old, a 13-year-old that can be 40 or 50. So you're playing rugby in that scenario and it's an age setup, then that's not great for injuries. We're also better at diagnosing it. There was a lot of injuries that probably went undiagnosed in children and just told to get on with it. You've had a sprained knee, don't worry about it. And also the higher demands on the sporting levels that children are participating at. It's not just after school games, it's national level and much more competitive sports than there's ever been for children. And also we're recording things better. And also we're doing more operations. So no longer are we limited with what we can achieve in somebody who's small. For instance, we've got tiny little arthroscopes that are maybe only a couple of millimeters across to be able to do arthroscopies, for instance, in 9-year-olds, 8-year-olds, whereas in the past, trying to use adult instruments to do that wouldn't have been possible. You wouldn't have been able to do the surgery, and therefore they would never have got an operation. So it's by virtue of our increasing skills, technology, lots of other things, that we're actually operating more and more and more on the children. So this is all very particularly relevant just now because there's a significant changing environment in the NHS. There's a vast centralisation of services. All the little cottage hospitals, all the hospitals that did everything are disappearing, and the big hospitals are becoming centres and hubs around the country to provide those specialist services. GIRFT is a very catchy name, obviously brought up with an orthopaedic surgeon, but it's getting it right first time, and the sentiment is absolutely great. And that's about making sure that if you're going to have an operation, you're going to have a treatment, that it happens in the right place with the most skilled person possible so that you get the best possible outcome. But not always is it really possible to centralise everything to a specialist area without robbing people of experience and skills where it's really necessary. Some of those services have now been robbed from hospitals. For instance, paediatric anaesthetists or paediatric intensive care, high care, suddenly disappears, and the services round about them crumble because although it's very rare, you can't do any kind of major surgery if you don't have the backup in the hospital. So this really separated surgeons to either adult or paediatric, and long gone are in some hospitals that the adult surgeons can suddenly go and do a paediatric operation because they're a soft tissue knee surgeon. I experienced that when I started doing some paediatric cases and showing an interest, and suddenly you realise the amount of VLE and bureaucracy that you need to fill in order to be able to be around a child, let alone operate on them, is quite extreme. And you put that out in lots of other hospitals, and it's just not feasible for them to manage that kind of service. However, the skills required for soft tissue surgery are really the skills that exist in adult surgeons who have a high volume arthroscopic practice, who do lots and lots of arthroscopic surgery. So the aim of this really is not looking at the children that are technically children. So obviously in Southampton and different hospitals around the country, it's different places, the age thresholds are different, but under 18 generally is treated as a child. But we all know that sort of 17, 18 is really just an adult. You know, you've got an adolescent maybe from an emotional maturity perspective may be slightly different, but from a physiological perspective, a size perspective, and some of the challenges that come with children don't exist. And actually these children can be essentially treated as adults, and often some of them choose to be treated as adults above the age of 16, which is their choice. This is really, this guidance is primarily aimed at those under the age of 16, where their physiology is much different, and also the impacts of their emotional maturity, particularly on how to manage them as inpatients, and also much more importantly, and we'll come to it later, is from a physio perspective in being able to rehabilitate and engage kids. Clinical examination is difficult. a child's much less able to give a clear history of the mechanism of injury, and examination is a bit more difficult. Clinical tests have got much lower sensitivity. Things like doing a pivot shift in a child who's not happy is not really going to prove anything. Many children are much more lax and bendy than adults, so actually what's normal, and thankfully they've got two limbs, and you can always check, but things like the laxity of their ligaments is very different, and it's also very different how the pathology exists. Everybody will be, I'm sure, familiar with the fact that sometimes their ligaments are stronger than their bones, and you'll end up with the situation that they pull off a chunk of bone rather than rupture a ligament. So the presence of a hemarthrosis should raise concerns of intra-articular injury. Also, the pediatric knee contains vascularity that's not seen in adult knees, and that causes difficult with interpretation of MRI scans and understanding what's on them. You can often interpret some things that look like a tear but actually are not, and then you're treating pathology that doesn't exist. And there's plenty of studies now to show that you can often miss meniscal tears in children, and it'd be the first presentations when you actually do the operation and do an arthroscopy of them. The other really practical thing is that they're just much smaller. So when you're doing an MRI scan and it's got 4mm slices, then you actually might, when you're jumping from one slice to the next, miss the pathology in between. So it's very relevant to understand all of those things when trying to put together a service that's going to treat these patients appropriately. Recommendations from it really said that all skeletally immature patients need followed up afterwards with imaging to make sure that they grow correctly afterwards. Often the operations that we do can interrupt where they're growing, and it's important that we keep an eye on that afterwards because they're such a dynamic being, unlike adults who don't grow and change. Interestingly, when they did the information gathering for this, that actually only 61% of respondents follow up pediatric ACL cases for more than a year. And actually it's important and that they set it out that you should see them at 6 months after their surgery, then at a year, then at 2 years. And it takes probably about 2 years for a physio bar to really to form. And if it's not formed by 2 years, it's not going to form. But equally, the fact that it's formed at 2 years doesn't stop you needing to keep an eye on them, because that can cause an isolated growth arrest within that, and then they dynamically change shape as the rest of their knee begins to grow, but that physio bar doesn't. And it can continue to produce deformity moving forwards. Then it gives some recommendations about the kind of surgeries that we do, probably not super relevant to a lot of the guys watching this, but typically an adult ACL reconstruction crosses the physis, and there's certain things that we need to take into consideration when doing a child's ACL, and there's been new techniques that have come that try to minimize the impact, and there's some techniques that allow us to do it all physial, so in the epiphysis completely, so avoiding the growth plate. And everybody thought this is going to be a fantastic thing. It avoids the problems of tethering the growth plate or causing physio bars, but nothing comes for free, and actually it's shown that you can get overgrowth because the trauma within the physis then attracts inflammation and new blood vessel formation, which brings actually increased growth. So instead of causing a growth arrest, it actually causes that part of the physis to grow faster, and you can end up with a growth disturbance. So it doesn't really matter what technique that we use. It's really just the most important thing is just to be aware that we need to keep an eye on these children after they've had a surgery around a growing bone, just to make sure that they don't end up in problems later with deformity. There are other things that we often do. It's not black and white. Your ACL or your PCL is not just a piece of string. So it's the thing that we can see that you manifest with. It's the hemarthrosis, it's the MRI finding that's really obvious. But we all know that there's a grey scale with an injury to a child's knee or anybody's knee with the ligament. Some people have a very isolated ACL injury, and some people have a much more gross laxity within their knees. And sometimes, particularly in children that are hyperlax or hypermobile, doing extra articular, so that means outside of the joint reconstruction, has become in vogue. And this paper actually goes on and gives recommendations with regards to that, and that some things are good. So you can do what's called a lateral tenodesis, which is an extra little ligament that's attached to help that rotational instability afterwards, and that works quite well. But ACL repair, which is different in that we don't reconstruct the ligament and take out the old ligament, but try and repair the one that's damaged, although logically makes a huge amount of sense, and I think long term is probably going to be really important, hasn't really been proven and isn't gold standard by any stretch of the imagination. And interestingly, these guidelines and this recommendation really kind of pushed away from doing that on a routine basis with children, and felt that if you are going to do it, it needs to be decided as part of a multidisciplinary team and to be done as a prospective study. So actually gathering all your data, making sure that you're actually understanding whether this technique actually works, and make sure obviously that the children and the parents understand that that's what's happening. Now that's very different to what I was describing before, where you pull off your ACL and a chunk of bone, where you get a tibial spine avulsion or a femoral avulsion, which is much rarer. That is not something that's controversial, and fixing those back down is absolutely the right thing to do. And the recommendations didn't recommend any differences than we would do currently. Again, you're getting into really niche stuff here, which is really important, but it highlights the differences between the pediatric and adult population, things that we just don't ever come across in the adult population. Congenital ligament deficiencies. So that's when somebody's born and doesn't have an ACL at all, and reconstructing in those patients. That's something that absolutely makes sense that should be done in a much more centralized specialist unit. It's not something that everybody sees every day, and even in those specialist units is something that would be very rare, and there's no real consensus on what the right thing to do is. So absolutely within these guidance telling us that we should be doing that not in a district general, not with somebody who doesn't normally do an arthroscopic procedures or does a few ACLs a year. That's something for somebody who does lots. Non-operative management. So this is interesting because again, it's from a physio perspective. I think this is quite relevant. The talk of conservatively managed ACLs is something that's not as popular as it ever used to be. I think the default now and the expectations of most patients and most surgeons and most other doctors is that if you have an ACL rupture, that you're going to end up with your ACL reconstructed unless there's a good reason not to. That's still something from this guidance that was said that you can still consider it in children. It's probably not something that happens very regularly or that you should be doing very regularly, just because of the potential collateral damage to a child's knee by leaving them with an unstable ACL. If you are going to do that, then it recommends that we need to do that in a very safe environment with a strong team of physios that can observe that child through that whole process, and make sure that they are rehabbed appropriately so that they're not unstable. If that person remains unstable, the recommendations absolutely are to go ahead and do something surgical. We know that leaving somebody unstable, and particularly longer than a year, their outcomes are much worse when you do reconstruct them, or that they end up with collateral meniscal or cartilage damage. So it's really, really important that if that's being done, there's a very, very good reason to do that. That kind of actually, I'll just quickly touch on that because it's very relevant at the moment where we have no capacity to do elective operating. And even in the situation where I see folk that have got a new traumatic meniscal tear with an ACL, with perhaps a bucket handle tear even of their knee, or a meniscus that's possibly repairable, at the moment, I'm still constrained in not being able to do that. I have to go through a committee and ask several levels and tiers of people before I'd be allowed to do that. So it may well be that from all of this during COVID that we actually have a whole cohort of patients who have been conservatively managed because there's just been no other option. But even now, I would push to operate on somebody who has an unstable knee and a meniscal injury. this is something that maybe people don't completely think about or expect, is that if you rupture your ACL, you're much higher chance of actually rupturing your ACL on your opposite side as well, not because of any kind of physiological change because you've ruptured your ACL, but just because clearly there's something with the way that you move or the situation that you're putting yourself in that is increasing your chance or your risk of rupturing the other side. What this recommended was that with anything that you should be auditing your own practice, auditing your own hospital, being able to highlight to people, what your rates of re-rupture in your hands are. However, if that's not data that's been collected, and it was interesting from looking at the survey information that they got in, that there's a lot of places really not collecting effective data, that you should probably quote a figure of about 1 in 4 risk of a combined either rupture of your ACL that you've had reconstructed or a contralateral ACL injury. And that's massive. If you were consenting somebody for a procedure or an operation and you had a 1 in 4 chance of having a complication, that would almost be unacceptable. So it's really, really important that patients understand. And this links to the very end when we talk about kind of preventative measures, and we'll talk about that in a minute, but it's really, really important that people understand that once you've had your ACL reconstructed, that's not it. That's not suddenly you fixed and bulletproof. There's so much more that has to go into it, and all the physios, I'm sure, agree that it's so unbelievably vital that people are rehabbed appropriately and have the understanding of what it is that they need to achieve, and that whole support needs to be there to prevent them not only damaging the ACL that you've just reconstructed, but the other side as well. And that takes us on just to meniscal surgery. And before we do that, I'm going to see if I can manage this system, and I think there's a bit of a lag and a delay, so I'm not sure how well that is, but if anybody wants to put in the chat any questions, I will try and answer. I'm very much a monotasker. I'm not a multitasker. That's why I'm a surgeon. So I'll keep an eye with my other eye and see whether anybody's got anything that they want to ask, and I'll try and address that in a wee minute. It then went on to kind of cover the other important structures within your knee, so the meniscus, and that, again, something that, because we've got the technology to do it and it's become much more accessible for more surgeons to be able to carry meniscal repair out, I think it's become very much more expected rather than something that's unusual. And it's really good that these recommendations are really quite forceful with their statement, saying that the primary goal should be to repair unless there's a really good reason why that's not possible. And even ones that are on the edge of being repairable, that it recommends that an attempt at repairing that meniscus is probably worth it. And then making sure that the family and the parents and the children know that there's a potential risk or a chance of failure that might require a further surgical intervention. It's interesting that different studies show different things, but between 15 and 24% failure for meniscal repair. I think all these figures are very much lagging behind the technology, and things are moving on so much that the repair of meniscus is almost something that should happen 100% of the time. As you get older, then that's quite different. In my knee, I'm sure if I had a complex tear of my meniscus, I've got a much less chance of it healing by being stitched back together, just because I don't have the healing potential that somebody who's 10, 11, 12. But it's an absolute crime if somebody primarily goes in and debrides the meniscus out of a 9 or a 10-year-old or anybody in that kind of age range. That's just devastating. So much more so than a ligament reconstruction, you can't get that meniscus back, and we know for a fact that that absolutely ends up with you having pathology and osteoarthritis and damage to your articular surfaces in the future. So it's really good that that statement has been made. It's also really important that those undertaking that care and doing the arthroscopy of the knee that might have a meniscus need to have the skills of being able to actually repair that meniscus. There's no point in going in there and you can do an arthroscopy of the knee, but then suddenly when faced with a meniscal repair, you don't know what to do, or you don't have the technology, or you don't do it regularly. I think I'd rather not have it repaired and then go back at a second time than have it repaired badly, because it's much more difficult to fix a poorly carried out surgical procedure than one that's not been done at all. So it's really important that it's high volume arthroscopic surgeons that are doing this, and very much one of these things that needs to be done by specialists. You need to be able to have, and one of the things that I always kind of make me feel comfortable during surgery is making sure that not only have I got plan A of what I'm expecting to do, but understand how to carry out plan B, C, D, E, and F. You need to have everything in your toolbox to be able to deal with everything that might come in front of you. And there's lots of different complex things within your knee with regards to meniscal tears. For instance, ramp lesions where this is where the meniscus that's actually attached to the meniscocapsular junction becomes a problem and needs you to be able to put a portal in the back of the knee. So not from the front, but the back. And if you're not doing that on a regular basis, that's not something that you should be doing. And without doing that, you're not going to be able to fix the problem properly. So it's really important that it's the right people doing that surgery. Meniscectomy should not be the primary treatment. That's just wrong. There's not very many things in life, in surgery and medicine, that are just wrong, but that is one of them. So this is a fascinating graph that was in the paper and in the guidance, which absolutely blew my mind, which was repair versus meniscectomy rates for trusts across the UK. And you can see the variation that you've got across the country. So, it just depends where you end up, depends on what happens to you, which is not how it should be. So hopefully guidance like this will stop that kind of mass variation that we see. So one thing that's unique to children that you tend not to see in adults, because it tends to have caused a problem before they ever get to that stage, is the discoid meniscus. So this is as you develop, your meniscus doesn't form that C-shaped, semilunar kind of typical shape that you see of the cartilage, and is much bigger. And a bit like having something trapped in between two rollers, when a child starts doing things or has a twisting injury to their knee or something else that happens, that cartilage, that meniscus can get trapped and torn. Saucerization, which is really kind of trimming the meniscus, so it's a bit more meniscal shaped, is the plan. But what's also really important, I'm glad that it mentioned, is that it's important, despite having a discoid meniscus, that you try and repair the meniscus. So if you've got a significant tear of that and you've saucerized it, but you need to give the meniscus back its function by tensioning it, then you need to repair it. In the old days, and not even the old days, and in some places across the country, somebody has a torn discoid meniscus, that's all coming out, which is just not good. And long term is going to be a big problem. And that's why it's led to developments such as things like meniscal allograft and transplant as a possible option to give you a meniscus back, because we just know it's so unbelievably devastating to take your meniscus out. But again, as you can imagine, doing a meniscal transplant is not something that you want to do one of. It's not something you want to have a go at. This is something that involves a huge kind of setup. So there's a few places around the country that do it. There's units that want to set up doing it, but it's an incredibly difficult thing to do to get the volume and the numbers. And it's still a technique that's developing, and actually the evidence for it's not fantastic yet. So any kind of surgery that's happening in this space needs to be part of studies, needs to be showing that we're achieving something good by doing this, not just having a procedure for the sake of it. So I'm glad this is another thing that was highlighted, and definitely something that needs to go into the specialist box. So I'm just going to take a quick moment and have a look and see if there's any questions. There's one from Mel South. It says, what time frame are the failures within? So it's interesting. The failures tend to not be with meniscal tears kind of immediate, because the patients are in that post-op recovery period and they're being a bit moving gingerly. They're not doing everything that they want to do. They're doing very fixed line type activities with you guys. And it's really when they start feeling much more comfortable and feeling much more brave and confident with their knee that they suddenly get out and start doing those kind of twisting, change of direction, deep flexion type maneuvers with their knee. And it's when your knee is probably in deep flexion, particularly with posterior horn meniscal repairs. If that meniscus hasn't repaired back to itself, I've got a knee here, and it's your knee's not like a, there we go. It's not like a cog or a wheel. It's not got a central pivot point. And our problem is that as you start to bend your knee, what happens is it rolls off the back, and as you can imagine, well, there we go. As you can imagine, as you go back, the posterior condyles start leaning on the posterior horn of your menisci, and that pushes them forwards. And if that's what we've stitched back with 2, 3 little stitches, and your body hasn't glued that back together, then it stands no chance with 60 kilograms of child and deep flexion pushing through that while running for a football. It's going to tear. So I would say it's kind of that 3-6 month phase is the first kind of peak that you start seeing people have problems if they've really had an unstable meniscus and it's not healed. Then you see kind of a second peak at kind of a year, 18 months down the line. So they kind of feel like they've got away with it, everything's good, they're back doing all their sports, and then boom, they do something relatively traumatic. They have an injury to their knee and they end up with a locked knee again. And when we go back into to view them, when you do an arthroscopy of that knee, you don't see a meniscus that would try to heal and that it torn again. This was something that was being held together with bits of braided nylon. This is something that hasn't healed. And in a sense, depending on the size of the meniscal tear the second time round, I would still have a go at potentially trying to re-repair some of those and give them some more stability and stimulate everything to try and get it to heal, because it's just that important that they're fixed. Emily C, how frequently and for how long do you follow up after meniscal surgery? So again, I think that depends entirely, Emily, on what meniscal surgery that they've actually had. If they've had a meniscal repair, then I tend to see them for about a year, and they've had absolutely no problems at that stage, then I tend to let them go. Sometimes more recently, about 3 months, I've been organising up-to-date MRI scans of their knee just to see if we can identify on the MR whether there's evidence of healing. And if there is evidence of healing and it looks as if it's all healed itself back together, then that gives us that little bit extra confidence to kind of let them get back to what they want to do. This is why this sort of guidance is fantastic, because actually there's going to be a consensus from everybody in orthopedics as to what regime we should be doing. Because if we're really honest, some stuff there is no evidence for, and to how long you follow somebody up and you use your common sense and you just kind of see in your own practice when things come back. I work on the principle that even once you're discharged, the door's open. If you want to come back and see me if there's any issues, any problems, these are such specific things that it's not a hidden problem. You don't have an ongoing tear in your meniscus without any symptoms that need something done. If your meniscal tear that's been repaired fails, it fails, and it's pretty obvious that it's failed. So the amount of follow-up, maybe not absolutely relevant, but I think it's important to see them regularly enough to reinforce the issue and the concerns, and that this is something that they need to be careful with. So this slide was interesting at the bottom, and they were very cautious on the return to sport. And it's one of these things that I've seen creep down and down and down. In adult side, it was always, you're going to be out for a year. You do your ACL, you're going to be out for a year. And then it was 9 months. And then you saw stuff in the press that people were back playing football at 6 months. And so naturally, there's an expectation from patients that, well, I'm going to do what the Premiership guys do, and I want to go back early. And in children, it's quite clear that it takes them a lot longer to achieve that kind of symmetry of their muscles, of their proprioception and everything else. And actually, it's really nice to see it in writing in a guideline that if there's any doubt at all, that really the expectation should be that you don't go back to sport for a year. And I think if you set that out at the beginning, then that's absolutely fine. And just reinforce it throughout the whole process of recovery so that there isn't this expectation of getting back at 6 months. And I'm sure everybody's seen it, the situation with the very high achieving child that's with a plan from everybody that they're going to be the next Wimbledon tennis star, they're going to be the next Premiership footballer. And actually, it's the kid looks like they don't really want to play, but it's the parents want everything to happen, and they're the ones that push things forward. So it's really, really important to be quite firm. And it's nice to have this on our side to be able to turn around and say, look, actually, the guidance is you shouldn't be back for a year. So that's it. The other really important thing, and I thought was probably interesting to hear from a lot of the physios, and something that I've been discussing with colleagues that I think we need to do an awful lot better at, is injury prevention and primary prevention of ACL injury and meniscal injury. And that's by engaging, school, the sports clubs, parents, and everybody else, and really kind of reinforcing that doing stretches, doing rehab, it's like there's a really good evidence from FIFA of a pre-warm-up simple exercises that reduce the rate of ACL injury and meniscal injury really quite dramatically, particularly in girls. And it's something that I certainly am going to be pushing with the school that my kids are at and other places, and trying to really engage in educating the importance of kind of exercise and that kind of understanding of proprioception for everybody before they start playing sport, to reduce the risk. As good as our surgery is, as good as technology is, and everything else that we do in the physio and everybody else that inputs into this stuff, we can't give them a normal ACL. There's lots of evidence to show that the mechanics of your knee are never the same after doing your ACL. So it's much better to prevent them having an ACL injury than trying to repair it as best we can. And this is really important. And this guidance really sets out that it's not just something that's done locally. It's not just us going to school or seeing all the PE teachers at school or the rugby teams and kind of encouraging this kind of attitude, but it's something that they said was incredibly important from a state level and a national level. So it'll be interesting to see whether we hear more about this through school or through the curriculums at school with regards to games. The other really important thing is obviously understanding whether what we're doing is actually achieving what we want. We have a lot of really poor evidence in medicine in general, and it's a lot of it's anecdotal. They go, all in my hands, it works really well, and actually that doesn't hold water anymore. And it's super important that we audit what we do and we prospectively collect data on what we do. There's a ligament registry. It's we've been proven that the joint registry for arthroplasty is an absolutely invaluable tool. And the same thing is happening with the ligament registry, but it's just not really picked up as much traction. But it's really, really important that we all understand what we're doing, whether it's working, any new techniques, whether they actually achieve what we want, so that we can weed out the things that work and the ones that don't. Outcome scores. And I think everybody understands that taking this stuff is probably really, really important. I don't think it really matters which of these scores that you do or what you take. I think it's the fact that you're taking the information from patients. But unfortunately, and I think moving forwards after all of this stuff, it's going to get even more difficult to do this. Trying to run a clinic and just keep your head above water with the amount that's coming through it is difficult enough without being able to take 20, 25 minutes, have an extra physio, an extended scope, somebody in your clinic, anybody to then sit down and ask an outcome score. For instance, this is the IKDC knee score. That's not something with a child that's going to take you 5 minutes that you can do at the end of your clinic. So I think there needs to be a fundamental change, and I'm glad that this guidance kind of recommends this, because it gives us much more ability to push our agenda and make sure that we're not just there service provision, getting people in and out and directing traffic, that we're actually giving the best possible service that we can and advancing things forwards. The other really important thing, I think, is that you don't stay kids forever. It's important to have a plan and know where you're going and be able to transfer those children that are in the adolescent stage that suddenly transfer from being 17 to 18 and having nobody that has any interest, nobody that's linked to the paediatric service, suddenly this person is starting again from scratch. They may as well be a new patient being referred by their GP, which is just not the way it should be. So it's really, really nice to see this quite forcefully recommended, that it's all part of a greater team. It's not two camps, and that patients flow seamlessly from one service into the next. And that's what's nice about being the adult surgeon who's kind of crossing the boundaries between the two, is that it makes it really easy for me to have patients that go from the paediatric service one day to suddenly turning up in my clinic in the adult side the next day, and nothing's really changed. It's just a different room. So it's fantastic. And also, the mindset of an adult surgeon is slightly different, and I'm looking to what surgeries they may end up needing as an adult, and making sure that things that we're deciding to do now when they're children aren't going to muddy the waters for the future, or put them in a situation that you're kind of hemmed in a corner with nowhere to go. So it's always having an eye on the future from the adult side, making sure that what we're achieving or trying to aim to get now as kids and fixing them is something that's going to do them well forever, or at least on that pathway that we know can happen as an adult. Interestingly, I like the idea that anybody that's discharged from the paediatric service should have a really detailed discharge letter, imagining that, if this was picked up by another person in another part of the country, could they continue their care? And I think that actually, scarily, that's not something that should just be for everybody. It shouldn't be a cryptic letter that only you understand or you know what's going on. This should be something that's transferable, that's no longer are the days that, unfortunately, these people are my patients for 25 years. They're the patients of the general or the patients of Winchester Hospital or wherever, and it doesn't matter who it is that sees them. Somebody else needs to be able to interpret that and manage them appropriately on what you've written. So I think that's something that, not just in this scenario, but just for everybody in general, should just keep in the back of our minds, that you need to be able to have somebody else be able to take over your work and understand what's been going on. So I think that's really important. And again, highlighted is that kind of specialization early, and the advantage of a pediatric fellowship is important. And being fellowship trained is not just one of these things that you put on your CV or you get a wee medal to show that you're a fellowship trained surgeon. The advantages of being and seeing somebody someplace else and in a very specialized and a different system is just so vital. It gives you links with people that are those that are setting the new standards for orthopedics, and for you to be able to actually contact them directly because you've been on a fellowship with them is just an incredibly powerful and valuable thing. I mean, for instance, I did a short fellowship with David de Jour, who is the master of instability of kneecaps. And not only did I learn stuff when I was there seeing him, but the fact that I can send him an email, send him some images, and get the opinion of the person who invented the operation as to what you should do with that child is unbelievably valuable, and not something that you can just achieve without going in and doing a fellowship. So it was really important. I'm glad that they mentioned the need for kind of educating our teams so that we can provide the best service possible. So let me just hide that. So I'm just going to have a quick look, see if there's any other questions that anybody's got. It says, you mentioned measuring skeletal maturity. Do you use x-rays and the riser classification or Fell's method, or just use MRI of the knee to calculate it? Thanks. So that's interesting, because that's one of the things that was actually mentioned within this, and that simply using, so it was interesting that the majority of people, when they're talking about skeletal maturity, use the Tanner system, which is non-radiological, and didn't feel that that was particularly relevant or something that we should be using. And it should be radiological, and it should be dealt with by specialist radiologists to provide a skeletal age for our patients. So not something that I would be doing. I'd be lying. I learned it during the FRCS. I understood how to do it at the time. It's not something that I would do now reliably. So I would delegate that. But I think the importance of it's not so much how you do it. I think it's important that it's radiological, but it's important that it's done by somebody who does it all the time. And again, this comes into the overall theme of this, which is making sure that the stuff that's really vital and that's specialist is done by specialists. Emma Martin, we have tried to involve my MR team in organising proms. It's a work in progress. Well, I applaud you for trying to do it. We've been trying to do it in the general. For the adult side, for joint arthroplasty, and the proms system is just really difficult. The questions themselves are not difficult. In an individual level, asking the patients to sit down on a computer and do it is not difficult. But you throw that into a day surgery unit where there's half a dozen computers, there's 30 patients, the anaesthetists are trying to use the same computers, I'm trying to use the same computers, and you're asking some patient who's in a hospital gown to go and sit on a bar stool and use a computer that's covered with notes to try and do proms is just not feasible. And I think it's just the infrastructure around about all of it that's just absolutely dreadful. And the only thing that I think, well, not the only thing, but one of the only things that's probably that's really good about what's been happening with COVID and everything else is that everybody's become so much more IT savvy. Everybody has a smartphone, a tablet, a computer, something they can use. My wife's a GP, and she's had 85-year-olds, 90-year-olds using a smartphone to do a video call. So nobody has any excuse anymore for not being able to access a computer and do some simple questions through a website. So hopefully this sort of stuff will get better in time, but it's still an incredibly difficult logistical process. And it's not something that's going to change quickly, but hopefully in the long term it will get better. Has anybody got any other questions that they want to put up in the chat, and I'll try and answer it. It's the satellite delay, so if I'm standing here looking as if I'm not saying anything, it's because I haven't actually got to that bit on the screen, so you've not written anything yet. So while we wait to see if anybody writes any more questions, I just want to thank everybody taking some time out to do this. I hope this has worked okay. I'm still kind of getting to grips with the technology of it. What will happen is that this will automatically get saved, and you can look things back through if you really want to. If you want to punish yourself twice in an evening, then you can obviously watch it again. What I'll try and do, there was people that were quite happy to go on to the mailing list with the Spire. Obviously with GDPR and all that kind of stuff, we can't automatically send emails to everybody that's involved. But if you don't mind going on an emailing list or anything like that, then please let us know. Alternatively, actually, if you subscribe to the YouTube channel thing, then it gives us an idea of who's around, who's interested in any other stuff that we want to do, or any other kind of webinars and things like that. We can let you know. All right. So nothing else on the chat. So I'm going to probably just leave it there for you guys, give you a reprieve, let you have the rest of your evening. If you have any questions, please don't hesitate just to email me. You can just do that through the website, or just at mark@wessex-knee.com. It doesn't matter if it's anything to do with this, or if it's just general clinical cases with regards to children, referral stuff, NHS private, doesn't really matter. If there's anything that you think is relevant that I might be able to help with, just give me an email. Always happy to interact in any way that I can and help you guys out. So thank you very much again. Oh no, I thought it was a question. It's not, it's a thank you. That's very nice. Thank you very much. And hopefully see everybody